Welcome to week 3 of Theories of Addictions. And in week 3, we've been looking at psychopathology and comorbidity, right? Substance use disorders, along with a major mental and emotional disorder. And in this lecture, lecture 2, I want to look specifically at the treatments for dual diagnosis. Remember, dual diagnosis means the individual has a mental emotional disorder along with a disorder, a substance use disorder. So I want to begin by looking at substance use disorder with depressive disorders. First, before I even jump into that, let's keep this thing in mind. In terms of treating dual diagnosis, kind of the old model was, and many people still believe this, that you treat the substance use disorder before you treat the mental emotional disorder. Because if we treat the logic was that if you treat the substance use disorder and that is eliminated, then we will see the person's real personality and real symptoms that may have been due to the substance use, and we get a better picture of whether they really have the mental or emotional disorder. That's the hypothesis. The newer and probably the more predominant approach toward treating dual diagnosis is to treat them simultaneously. And part of the logic there is, well, one, clients like that better. Two, what if, hypothetically, the client has a pretty severe anxiety disorder, maybe a difficult case of generalized anxiety disorder, and they gravitated into a substance use disorder to treat the symptoms of the anxiety. The logic here is that if we don't treat them simultaneously and we eliminate the substance use disorder, we've left the client with the anxiety that it drove them toward the substance use disorder anyway, and so we set them up perhaps for failure. So the more dominant way is to treat them simultaneously. So let's go back to look at depressive disorders along with substance use disorder. In this course, we're not going to be going into the diagnosis of all of these disorders. We want to get it's theories of addiction, so we want to get a general idea. But in other courses where we really focus on how to diagnose them, we'll go into much more detail. And we'll go into much more detail on treatment of those disorders in several of the specific courses in addictions. So depressive disorders, what do we mean by that? Well, a depressive disorder, there are numerous depressive disorders. One is major depressive disorder. Another one is persistent depressive disorder. How do those two differ? Well, major depressive disorder has more intense symptoms. Persistent depressive disorder is a lower lying, used to be called dysthymia, lower lying depression that lasts for at least 2 years. Major depressive disorder, there's one necessary symptom. If you're an adult, children are different. If you're an adult, the individual has to have experienced sadness for at least a period of 2 weeks, and then have 5 among 9 other symptoms in some combination. So one of the things we need to do when we're looking at treatment of an individual with a depressive disorder and a dual diagnosis, with a substance use disorder, is to look at how we're going to treat both of those simultaneously. Fortunately, some of the treatments, some of the models that are used to treat mental and emotional disorders are helpful for treating substance use disorders and vice versa, which is really, really helpful now. So what do we have to do? First, of course, we always have to assess for the presence of a mental emotional disorder or substance use disorder. And so we would need to assess for the actual presence of some form of depressive disorder. And we do that One, in many ways, we're going to do an diagnostic interview with them to see whether the individual satisfies the necessary necessary and sufficient conditions to have a particular disorder, or what we call they fulfill the diagnostic criteria for a particular disorder. So one is we look at the family history. Has a family member been diagnosed with some depressive disorder or substance use disorder? Are there current stressors, real recent or current stressors in their environment that may give rise to the depressive symptoms? If they are, then we would be more likely to call it an adjustment disorder. It's due to external situations. Whereas if it's not a recent stressor, then maybe the cause is not external but internal. We may have a predisposition to develop major depressive disorder, some endogenous depression that may also be triggered by external situations, etc. And an important one is to time the appearance of symptoms. Did the individual have depressive symptoms before they showed any evidence of a substance use disorder? Because then we may know what was driving the substance use disorder. There are some screening tools that will help us to pick up on depression. The Beck Depression Inventory is a very short measure, pen and paper tool, instrument, a survey that an individual can take very, very quickly in session. There's also another one that's used rather frequently, and that's the Hamilton rating scale for depression. And then the Patient Health Questionnaire number 9, which is actually quite good. Once we do a thorough assessment using some of these screening tools, and we look at the satisfaction of diagnostic criteria as found in the DSM-5, then we develop a treatment plan, and then we look at two other things. Are there psychotherapies that are helpful? And then with input from medical personnel who can prescribe, does this situation warrant medication, right? Also, also in terms of what the client wants on these things. So in terms of psychotherapies, there are several things that we need to consider. One would be the client preference in psychotherapy. There are some psychotherapies that are short-term. There are some that are longer-term. There are those psychotherapies that want to go back and explore the past quite a bit. And there are those therapies that want to focus in pretty much the here and now, and perhaps the thoughts, etc., that an individual has that sabotages them reaching their life goals or causes some disturbed emotions, right? So we have to look at the client preferences. Excuse me. And then we also need to look at the availability of psychotherapy within the environment of the client, where geography. So maybe there are some psychotherapies that would be quite good, but they're not particularly available within driving distance, etc. So we have to look at what's available. And then third, it is best if we recommend to a client the use of an evidence-based model. What we mean by an evidence-based model, and particularly now we're talking about depression, is that we would look at those models of psychotherapy, those treatments in psychotherapy for depression, and have scientifically tested them over time, had repeated studies to determine whether they are effective and efficacious in the treatment of the depression. And so, and it's better if we kind of recommend those individuals to evidence-based models, because we know that there's a greater tendency for them to work. If a model is not been determined to be evidence-based, it doesn't mean that it won't work necessarily, but it doesn't have the statistical backing, the scientific backing that an evidence-based model would. And so some of the evidence-based models for depression are second wave, what we call second wave behavioral models. Those would be like cognitive behavioral therapy and rational emotive behavioral therapy are often quite good in treating depression. Okay? In addition to that, numerous medications have arisen and are used to treat depression, and we'll take a look at those. Remember, a client doesn't go in and say, "Put me on this." I mean, they may try, but this is up to an individual who is licensed by the state or the region to prescribe medications, and they have to make that determination. Okay, but the common medication classes are what we call SSRIs, the selective serotonin reuptake inhibitors. Some of the popular medications in that category are Prozac, Paxil, Zoloft, Celexa, and they work by increasing the level of serotonin within the brain. Remember, serotonin is one of those neurotransmitters, and if the levels are low, then an individual begins to ruminate and becomes symptomatic. And so a sense of well-being is increased when we have adequate levels of serotonin. So that's how the SSRIs work. And then there's what's called the SNRIs. These are selective norepinephrine reuptake inhibitors. So they raise not serotonin, but norepinephrine levels within the brain. And some of those antidepressants that do that are Effexor, Pristiq, Cymbalta, and so forth. Also, there are those medications that raise another one, dopamine. And remember, dopamine is really important in triggering the pleasure-seeking behaviors and pleasure centers within the brain. So dopamine has individuals feel better too. So Wellbutrin, for example, helps raise dopamine as well as norepinephrine levels within the brain. There's another medication called trazodone that raises serotonin levels within the brain, although it is not an SSRI. It works on serotonin, but not in the same manner that the SSRIs do. And then there are other Remeron, which is often prescribed because it gives, for individuals who have really great difficulty sleeping, because it has a sedation effect, and it does raise serotonin and norepinephrine levels. Now, there are older antidepressants. The ones that I just gave you are the newer antidepressants. The older ones are like the tricyclics, like Elavil, or nortriptyline, those. There's a downside to some of these because the difference between the therapeutic dose and the lethal dose is not very great. So there's a risk that an individual could overdose, and often overdose with the tricyclics can result in death. So, and then also for older clients, there can be some cardiac problems. And then an even older one is what's called the MAOI inhibitors, the monoamine oxidase inhibitors. And these are rarely prescribed today. They may only do that as a last effort if the other meds are not working. As I said, they're rarely prescribed because there's strict dietary restrictions. We have to keep a particular chemical at a low level within the body. And for example, if people eat like certain kinds of cheeses or pickled foods, etc., that can cause, and they have hypertension, that can raise the blood pressure to really, really dangerous levels. And then another treatment is electroshock therapy, which electrodes put on the skull, and the light shock is given. It's not like in the old days, what you've seen in the movies where people go into great convulsions and all of that. It's a much milder dosage. They're not quite sure why that works, but for a good number of individuals, it does. And so some of the SSRIs and antidepressants are helpful in treating some of these substance use disorders too, particularly if they have depressive symptoms. Another category that we see associated with substance use disorder is a bipolar disorder. Bipolar disorder and depressive disorders fall into a category called mood disorders. So within the category mood disorders, there are depressive disorders and there are bipolar disorders. And among bipolar, there tend to be about 3 different disorders: bipolar 1, bipolar 2, and cyclothymia. With bipolar 1, the individual has to, within their life, had at least one manic episode. A manic episode is where the individual may have racing thoughts, great difficulty sleeping. They may go days without sleeping. They may lose touch with reality, engage in very risky behavior, etc., and actually cause damage to themselves or others because of the risky behavior that they may engage in. So, and then bipolar 2, they don't have full manic episodes, they have hypomanic episodes and more depressive episodes. So hypomania would be elevated mood, but not elevated up to the level of a mania. They would not tend to have delusions and hallucinations that may occur with bipolar 1. Not all bipolar 1 would have delusions and hallucinations, but some would. And so and then there's cyclothymia, where they have elevated mood, not to the level of bipolar 1 or 2, and then a lower mood, but not to the level of a major depressive depression. So kind of a cyclical. So that's thus the name cyclothymia. So what do we have to do? We have to assess for the presence of certain things. 1, we have to assess whether there's mania or hypomania. 2, we have to assess for the presence of depressive symptoms, because bipolar 1 and bipolar 2 can have some depressive symptoms. We have to see whether there are delusions and hallucinations or mixed symptoms, right? And so there are some assessment instruments. One that is really helpful is to have clients keep a mood log, right? And sometimes these are on paper and pencil. Right now, there are apps available, on your phone or a computer, and it's always good to talk to a psychotherapist about the possible use of those apps. But and some of them will then allow you to send that to the therapist. So that always needs to be discussed with a therapist. So keeping a mood log can be helpful. The ones that were used for depression could be used here again. But in addition to the ones for depression, there's what's called the Young Mania Rating Scale, which is quite good for testing for the presence of mania, or the Mood Disorders Questionnaire that the client can take. So that's how we assess and diagnose, but then what can we do? What are psychotherapies that may be helpful, and are there medications that may be helpful? Well, let's look at the psychotherapies. And here, bipolar warrants some serious consideration of psychotherapy. One would be psychoeducation about bipolar. It is really important for someone who has bipolar to understand the nature of the disorder, to understand what's going on when they have particular symptoms like the racing thoughts, or difficulty getting out of bed, or engaging in risky behavior and then becoming depressed because they engage in the risky behavior. So psychoeducation is really, really important. They also frequently will need some medication, although that is the judgment of a prescriber, a licensed prescriber. And it's really important for the individual to know about the medication and be educated on those. And because Many medications also have side effects that it's important for the clients to know. Otherwise, if they don't know about the side effects and something happens, then they may just take themselves off the medication when maybe that wouldn't be a great idea. Peer support groups can be really helpful. One great organization that has peer support groups in the United States in so many different places is NAMI, the National Alliance for the Mentally Ill. And they even have family to family, so that family members of individuals with bipolar and other major mental and emotional disorders can seek peer support. In addition, we can help the client monitor the warning signs. There are warning signs that mania is coming or depression is coming. And one of the things that many people with bipolar have found helpful, not only bipolar, but other mental emotional disorders, is a program called WRAP, Wellness Recovery Action Plan. And the individual describes what she or he is like when they're asymptomatic, when no symptoms are going on, and they give a list of that. And then what do they do to try to stay asymptomatic? And then they write down what they're like when the symptoms are beginning. What do they do? And in addition, what do they need to add to the things that they normally do to stay well? Maybe they need to make an appointment with a therapist. Maybe they need to go see whether medication is called for. Maybe they need to join the peer support group then. Okay, so this is all part of the Wellness Recovery Action Plan. And then it goes to, considers the progressive, if the symptoms progress, or even if they are in crisis, what kinds of things need to be done. And it's really helpful. They write out the Wellness Recovery Action Plan. They can do that with a therapist. They can do it with a psychiatrist, et cetera, so that they sometimes share that and collaborate with the mental health provider, and it's a great program. One thing is to develop healthy habits, exercise, eat well, sleep hygiene, those kinds of things. And also the education on the links between bipolar and substance use disorder, so that they become aware that with the symptom, they may be at greater risk to develop a substance use disorder, and to pay attention to that and maybe have others in their environment help them with that. And then, of course, family support can be tremendously important there, and peer support, and even friends support, etc. What about medications? Well, lithium and in different forms of medications has been proven to be helpful. The client does have to have regular blood tests to make sure that there's no toxicity, and it does need to be monitored. Some of the anticonvulsant medications have been found to be mood stabilizers, and so will help the individual from flipping between mania and depression and keep them on a more even keel. And then the antipsychotics, particularly those antipsychotics for those times when the individual is struggling with reality testing or having delusions, hallucinations, and that kind of thing. Part of the problem with these antipsychotics, although they can be really helpful, is they do need to monitor the blood glucose, because it can raise that, cause weight gain, and then predispose somebody to the development of diabetes. And so that's about it. If we shift over to anxiety disorders and substance use disorders. One, we have to do the assessment according to the diagnostic criteria as found in the DSM-5, right? And as I said, we have a whole course on just how to do that. There are some instruments that are helpful, like the Beck anxiety instrument is really helpful, very short. You just click it. There's another one called the Zung, and others that can be quite helpful there. And then it is really important for the clinician to distinguish the types of anxiety that the individual has. There are multiple forms of anxiety, and I don't have time to go through those, but there are certain forms of anxiety disorders may predispose the individual to certain types of substance use disorders. So for example, one that's called generalized anxiety disorder, which is worry about all kinds of things, what many people would call worrywarts, but just get so many worries and riddled with anxiety. Well, we found that teens who have a generalized anxiety disorder have a greater risk for developing a substance use disorder. Those individuals with social phobia, who are afraid of performing in public or around groups or social interactions, they're worried about doing something wrong and being negatively evaluated or seen in a poor light, are also at high risk for the development of substance use disorder, higher risk. And then panic disorder. If an individual has a panic disorder, they have a 4 times greater risk for developing alcoholism. So it's really important to pay attention to these. Also, panic disorders, sometimes there are medications, benzodiazepines, that are given for panic disorder, and it's very important that they take them short term, not over a long period of time, because the benzodiazepines are highly addictive. What about psychotherapy? Yeah, there are some psychotherapies that are very, very helpful for the treatment of anxiety disorders. And again, the second wave behavioral models, cognitive behavioral model, rational emotive behavioral model, can be really, really helpful along with motivational interviewing. In fact, you can use the second wave models with motivational interviewing together, and that can be quite helpful for anxiety. Remember, one of the things that is behind all anxiety is the inference, is what? The interpretation of a situation, event, something as a threat to us. Think about it. If you think that you are under threat, something is threatening, then there's a greater likelihood that you experience anxiety. The problem is, for like generalized anxiety disorder, people see threats or infer threats when there are no threats. Or there's a low probability of a threat, okay? So one of the things that the therapies can do is to help the individual assess the reality of the threat and then also deal with the resulting beliefs like, oh, this is terrible, this is horrible, I can't stand this, when they have those anxiety symptoms, and to work at that level. And that's what those second wave models do and why they're so helpful here. So what are given to treat anxiety? Well, it's really rather interesting. Many of the antidepressants, the newer antidepressants, especially the SSRIs, are given for the treatment of anxiety, so they can help the anxiety and depression if it's there. And then also the benzodiazepines. Benzodiazepines are, they work by raising gamma-aminobutyric acid, GABA levels in the brain, and which give an overall sense of well-being, but they act very, very quickly, and the individual feels good very, very quickly. And because they act quickly and the individual feels good very, very quickly, they are highly addictive, right? Benzos are one of the most misused medications around, and so those have to be used very short term and not over a long period of time. Another one is post-traumatic stress disorder, a trauma-related disorder, and substance use disorders. And remember, post-traumatic stress disorder is a major and difficult disorder at times. There are symptoms within particular categories. One is that there are intrusive thoughts. Some of these thoughts can be in terms of flashbacks. If you've been traumatized, maybe within battle or with a car wreck or rape or a hurricane, these kinds of images and flashbacks can occur, and those are intrusive thoughts, and you can imagine how upsetting those intrusive thoughts are. Also associated is the category of symptoms called avoidance symptoms. Avoidance symptoms are there because post-traumatic stress disorder used to be an anxiety disorder. Now it's no longer put under an anxiety disorder label. It is under the trauma-related disorders, but there's still a lot of anxiety accompanying post-traumatic stress disorder. And remember, the inference when we have anxiety is that there is a threat. And what do we want to do if there's a threat? We want to avoid the threat. And that's what happens. These individuals may avoid things. They may avoid being around family and friends. They may avoid social situations. They may avoid social gatherings that they really liked before. So they engage in that avoidance, okay? Another set of symptoms is what we call physiological arousal. This is when they have those intrusive thoughts or whatever, or maybe it's 4th of July and they hear fireworks and it reminds them of gunfire or whatever. Then the body becomes physiologically aroused because the sympathetic nervous system is activated. And when it's activated, we want to fight, flight, freeze, or faint. And so that is kind of what happens, right? They're ready for action, whether it's to fight it or just faint. Both are adaptive ways to deal with a major, major threat. But sometimes in post-traumatic stress disorder, they see threats or they infer threats where they're not really there, so they could be easily triggered, unfortunately. So you can imagine with individuals experiencing these very painful, intrusive thoughts and having this ongoing physiological arousal, which can be really, they're hyper alert and aroused, that they often gravitate toward using medications or drugs to calm themselves and become addicted. And then there are also a class of symptoms called negative emotions or moods: depression, anger, fear, rage, all very negative and typically dysfunctional emotions. Another category would be what we call disturbed cognitions. Thoughts that would be unhelpful thoughts about the self, others, life, and world. About the self: I'm broken, I'm useless, I'm not the person I used to be. Or others: you can't be trusted, they're all threats, they're all out to get me, Or the world is a horrible place. So disturbed cognitions that are not helpful. Now, there are scales that will help us to pick up PTSD symptoms. One's called the PTSD symptom checklist, very, very helpful. And then another one called the trauma screening questionnaire, which is really good for picking up trauma. What about psychotherapies? Well, fortunately, a number of really good psychotherapies have been developed. This is my area of specialization. And if we look at the list of evidence-based psychotherapies for the treatment of PTSD and other trauma-related disorders, we see that they kind of fall into two major categories. There are what are called exposure treatments, and then there are present-centered treatments. Exposure treatments, and both of them have really good outcomes. Exposure treatments would be having the individual imaginatively go back to the experience of the trauma and discuss that, and the therapist would help them in that process. The present-centered therapy will totally refrain from doing the exposure. And what they do is to look at the symptoms that the individual with PTSD has in the present and ways that they can better deal with that. So one of the most prevalent exposure therapies is prolonged exposure therapy, which is often used by the military and other and private practice and in groups with great success. And then present-centered therapy, one that I really like there, is called Seeking Safety. It is a treatment for both PTSD and substance use disorder, which is really nice because that kind of Seeking Safety will get at the treatment of both of those. It can be done as a group or in individual. And again, it focuses on how to deal with symptoms in the present. If we compare the two of these, both have about the same great outcomes, but the dropout rate for exposure therapy is considerably greater than for present-centered therapies. Because as you can imagine, when you're imaginatively going back to to the traumatizing event, that can be emotionally somewhat painful. So, but it's really up to the client and in discussion with the therapist. There are some kinds of treatment that are actually harmful. That is, and those are if immediately after the trauma, they get people in a group and they have them process that. Often what we see is that the post-traumatic stress disorder gets worse later on. We're not quite sure about that, but they think it is because the body has its own adaptive mechanism. The body does an amazing job. So for example, at 9/11, in New York City, about 25 to 30% of individuals who saw those horrendous sights, people jumping from buildings and body parts, I mean, really, really difficult things to see. About 25 to 30% of them developed PTSD, which means about 70 to 75% don't. So the body does a pretty good job of handling that. And so sometimes I think that if you get people together, immediately talk about that and process that, that disrupts the body's normal adaptive mechanisms. We're not sure about that. Are there any medication treatments for it? Well, yeah. I mean, antidepressants have been used if depression is present with PTSD. Something called alpha-adrenergic agents, which were blood pressure pills, which means if they take those, then the individual isn't physiologically aroused. If they're not physiologically aroused, and that physiological arousal isn't attached to the memory, then that may help the individual from developing PTSD. Some of the atypical antipsychotics, can be helpful here. Again, they have the problem of weight gain, raising blood glucose levels, and predisposing somebody for the development of diabetes. And then benzodiazepine. Again, benzodiazepine, as we discussed with treatment of anxiety, it needs to be short-term treatment given the tendency toward the addiction. I'm not going to be covering schizophrenia and substance use disorder. There's a good section in the text on that, but I do want to say a little bit about the personality disorders and substance use disorders. Once personality disorders take some time to diagnose. We need to take our time diagnostically because there has to be symptomatology over a long period of time. And so we really need to do a really good history to see how long the symptoms of the personality disorders, as discussed in the previous lecture, have been present. So we have to do a thorough assessment based upon the DSM-5. One measure that can be quite helpful is what's called the MCMI. The Milan is really quite helpful for this because it mirrors the DSM-5 categories, and so it can pick up different types of personality disorders. Also, for personality disorders, and we see this for other disorders, especially depression and PTSD, but also for some of the more difficult anxiety disorders, we always need to assess for suicidality. Is the individual thinking of suicide? Either passively, passively means they're thinking about death, but they don't have a plan, or actively if they have a plan. And of course, if they have a plan, then the risk factor goes way up. And if they have a plan that involves very lethal means like using a gun or hanging, then the risk goes even greater. So we always need to do a thorough assessment for suicidality, okay? And we want to do that with personality disorders. No meds have been approved for the direct treatment of personality disorders, and for some believe that is one of the challenges because there's no medication. However, some psychiatrists do prescribe medications based on some of the symptoms. So for example, sometimes individual personality may be highly angry. Well, there are certain medications that may help them be less angry. There are some psychotherapies that are helpful. The primo psychotherapy is what's called dialectical behavioral therapy. We call it DBT. Excellent, excellent psychotherapy. I think it was first used for treatment of borderline personality disorder. It still is, and it's wonderful if there's a DBT therapist in the area or more than one. By the way, DBT is also good for, remember we said with borderline personality disorder, there can be really inordinate anger. And so it may be also used for anger management. Some of the second wave of behavioral models, this cognitive behavioral or rational motor behavioral therapy, CBT and REBT can be helpful for this. Motivational interviewing has been found to be helpful. And then there are some things to remember. Any client who presents with a substance use disorder, you must check for the presence of a mental or emotional disorder. It's malpractice not to do that. And if an individual presents with a mental and emotional disorder, it is extremely important to check for the presence of a substance use disorder, okay? And remember, there are particular kinds of diagnoses that are more prone than others to develop substance use disorder. But an individual with a mental emotional disorder is going to be more prone to develop a substance use disorder than someone who does not have a mental emotional disorder. And some of those that we really want to look at quite closely when we're assessing for the presence of a substance use disorder are the mood disorders, the major depressive disorder and the bipolar disorders, the anxiety disorders in all their forms, and we would put PTSD in there since it used to be an anxiety disorder, and of course the personality disorders. Another one that we haven't talked about is eating disorders. Many individuals who have an eating disorder, particularly if they engage in vomiting as a way to deal with the fear of eating and the fear of gaining weight, is one of the ways that makes it easier to do that is to drink alcohol. So they may gravitate toward drinking alcohol as a way to help the elimination, okay, of the food. So I hope you found that helpful, and look forward to the next class with you, and have a great week. Goodbye.
The Masters of Arts in Addictions Counseling at Columbia International University prepares graduates to be successful in an occupation that is experiencing job growth at a tremendous rate. This program integrates faith with evidence-based knowledge and practice in diagnosing and treating addictive disorders from substance abuse to behavioral addictions. CIU's Master of Arts in Addictions Counseling is the only academic program within the U.S. to offer certificates in addictions counseling through the Albert Ellis Institute, an international mental health professional training institute. Enroll today at CIU.